Treatment plans are so important in treatment for a variety of reasons. They obviously guide the treatment. They tell you when the client has achieved all of their treatment plan goals. Therefore, they're ready to terminate, discharge, or graduate. Clients are asking, when am I ready to be done? But this is really based upon the client. The answer is when you achieve all of your treatment plan goals. It's not based upon the counselor's subjective opinion of being done. Treatment plans are a way of measuring outcomes for the program. X percentage of clients achieve their treatment plan goals, or X percent is our completion graduation rate. Treatment plans are conducted every 90 days for Medi-Cal as a funding source. They may be longer or shorter depending upon the agency's funding source. In effect, you will be doing lots of treatment plans. So here's one more chance to practice. In the Files menu under Assignments, you will find the optional extra credit for a new treatment plan for Lee C. This optional extra credit is worth 10 points and should be submitted through the module for Week 8. Use the treatment plan form that you are familiar with under the Forms in the menu on the left. Now, on to Chapter 21 and this week's video assignment for video number 4, Preparing for a Service Planning Conference. The Service Planning Conference is also called the Treatment Team Meeting or the Case Planning Consultation. A treatment or service planning conference is a meeting in which professionals get together to discuss new cases and to make decisions about how to handle each existing case. The meeting involves professionals collaborating together to determine what is best for the client. You need to bring to the conference or to the meeting your tentative treatment plan for the client you are seeing, a human service directory, or at least a good long list of the community resources that you know about that you will be recommending for your client, your DSM-5 handbook, the client file, or your laptop if you have an electronic health record. This professional treatment team meeting, where you will present your plans to provide services to the client, would typically be made up of a multidisciplinary team of professionals. For example, in the team meeting could be the psychiatrist, the nurse, the therapist, the case managers, and the supervisor. It is usually the same team of professionals that meets on a regular weekly basis to discuss cases and is a good opportunity to present cases that are new to you, cases that you are stuck on, or those that are not progressing well, to get some ideas about how to increase the services to make a difference for the client's success. Treatment teams do not violate confidentiality because all of you are professionals who regularly work together for the benefit of the client. There should not be anyone in the meeting without a need to know. For example, a clerical person may be in the meeting or for part of the meeting because they have a need to know about the client's status of each case, and they may be changing it in the electronic health record as you discuss the cases. But if the clerical person does not have a need to know, then they should not automatically be in the room. If your treatment team includes other professionals outside of your agency professionals, for example, probation officers or another ABC agency staff, then you would need to ensure that every client being discussed does have a release of information in their file with probation or with that other ABC agency. In the quiz, the answer for this question, however, is a treatment planning meeting done with a team is a collaborative activity. You are professional, and so are the other members of the team. It is not appropriate to roll your eyes or to argue about the treatment plan or to downgrade your coworker's work with the client. You are there to provide appropriate feedback in a sensitive and caring manner. For example, have you thought about a referral to the women's shelter? Or, I'm wondering about what stage of change do you think this client is at? Maybe the interventions that you are doing are not matching with that stage of change. Collaboration. Meeting with staff to determine a final plan and diagnosis is a collaborative process. Expect to answer questions. Expect to receive suggestions from others. Do not expect that the plan you have in mind will be the final plan. You are not going into the meeting with a predetermined plan. You are not reading the plan that you have already developed. This meeting is a conversation about the clients. Remember to consider both the client's strengths and expectations of their whole treatment plan. It does not make sense to have a very complicated treatment plan or a treatment plan that is overwhelming to the client. You should get and receive feedback from your coworkers on if the treatment plan sounds reasonable, achievable, and is realistic for the client. Be open to changing the plan. In video number 4 demonstration, you are presenting your case for termination to the multidisciplinary team. You feel that your client is ready to be discharged, either successfully or unsuccessfully, and so you need to present the team so that others can approve or sign off on your plan to discharge. Maybe the supervisor, for example, has decided to go ahead and offer some more or different treatment that may help the client be even more successful, and so you all discuss this. Or maybe the client was scheduled for graduation, but the last drug test was positive. What shall we do? Go ahead and graduate, or have them continue in treatment? If so, for how long? Look over the grading rubric for video number 4. Your first sentence for your presentation is the presenting problem. Remember this all-encompassing statement that is on the new inquiry form? Or the presenting problem is also the first section on the assessment write-up. It goes something like, client is an XX-year-old, ethnicity, gender, other descriptors, who came to Wildwood Case Management Unit for 1, 2, 3 issues. Describe a little bit more about all 3 of the issues. For example, has been using drugs pretty much consistently since age 12. Or currently sleeping in their car and would like housing as the weather is turning colder. And would like to work on sobriety. As the client stated, they are getting tired of using drugs and is starting to experience health issues from it. Next, discuss information from the assessment over the length of the case. Here you will demonstrate your other knowledge and clinical language, such as the stage of change, your DSM-5 language, your level of case management, family systems descriptions, and other items of interest in this case. Next, you will discuss the treatment plan that was developed from this presenting problem list. Or perhaps the treatment plan changed from the initial problem, and that's okay. Don't read the treatment plan. You are summarizing briefly. Next, in your meeting, your video demonstration, describe what you and the client did during the case management sessions. What interventions were especially effective? What progress did the client make in completing their homework or assignments? You can find information to discuss during this part of the presentation from your progress notes. Don't read your progress notes. Summarize some interesting interventions. Lastly, describe your impressions and recommendation for the client. What is their discharge status? Clearly state whether the client is completing successfully, unsuccessfully, or a partial success. Making the presentation on your video. Be prepared to talk to the team in your video for about 5 minutes. You should be able to talk about the client without a lot of notes, but it is all right to use notes to give details that perhaps you don't know of offhand. In real life, the team would ask you questions about the client. Be prepared to answer questions about your client from the other team members. Of course, in your video, we will not be needing to demonstrate this. These meetings are a collaborative activity. Watch the case planning meeting as presented in the module. Also, see the grading rubric for the case presentation for video number 4. The follow-up after the meeting. So after the treatment team, write up the formal service or treatment plan, or in our case, you'll be writing up the discharge summary next. Meet with the client to discuss the plan. Make sure this is what the client wants. You may need to make a few minor adjustments to the discharge summary or the treatment plan. Make referrals to provider agencies where the client will receive any ongoing services or treatment. Again, the referrals that you make, even after a client is discharged, need to have a valid signed release of information. If you are going to do a referral notification this form, so go back and check your release of information forms and choose one of the referrals that you will do for the notification form. You will want to do a different agency referral, then you need to also fill out a new release of information form. See the forms in the menu on the left under Forms. So, for the referral notification form, worth 10 points this week. Fill this out in black or blue ink with your client using your client's treatment plan or recommendation section of your social history intake assessment. You will need at least one referral notification form for your client. In real life, referral forms can be faxed or sent electronically or by regular postal mail. There is now acceptable use of email to encrypt and attach referral forms to email. On to Chapter 22 and Chapter 23 on documentation. Be factual and balanced in your documentation. Remember that the facts of the client's situation, which they have given to you, and which you have placed in documents written within the client chart or electronic health record, EHR, belong to the client. It is entirely possible that the client will request to read their chart. So be factual, professional, objective, and balanced. There should be evidence in the written record that you and the program to which the client was referred agree on the plan, and that the client was involved and also agrees to the plan for their treatment. Don't write too much, but don't be too brief. See the face sheet under Forms. This form also needs to be filled out on your client and submitted in the module. Fill out each box on the face sheet. Don't leave blanks. Instead, use NA as needed. The face sheet is a single location for a snapshot of the client's essential information. It is an easy access point for client information in case there's like an emergency or your supervisor needs a quick summary or a quick check on your clients. Electronic Health Records, or EHR. By January 2014, all health facilities were to have an electronic health record for patients. The EHR must be able to record client information as well as to provide billing to the federal government in an electronic format. The EHR must also have interoperability to be connected and allow information, usually through an exchange, shared with other health providers, hospital to primary care physician. So now all of your doctors and so forth can see all of your different records. And you don't need to wait. If you had an x-ray at the hospital, your primary care physician will get access to that x-ray right away. And so you don't need to wait any longer. Those are some of the benefits of an electronic health record. But STAR, our agency, still has paper records. Well, maybe your agency is not considered a health facility, so that is fine. Or maybe you don't do billing to the federal government, and so you get money and funding from other ways, and paper records are still allowed. But for those who are considered health facilities and those that do billing, such as Medi-Cal, to the federal government, you do need to have electronic format client records. Meaningful use. The EHR is also required to have meaningful use meaning benefits, for the patient. Some options, for example, the client can request a list of medications available at each visit, or they can request a summary of the session given to the client at the end of that same session. There could be tobacco cessation planning in addition to other healthcare provided, or obesity prevention planning, because the physician can also see weight and blood pressure and those kinds of things across venues. What does all this mean to you? Well, as a new counselor coming into the field, you should expect paperless charting. That means typing skills are a must. Understand the charting language. Adhere to governmental requirements. There is such a thing as electronic signatures. And yay, matching elements are done automatically. So unlike paper records where you have to write the client's name, just as you did in this course, on every single form, in an electronic health record, the computer already knows the client's name, and so it prints it out for you on each and every single page. Yay! What else does this mean? Well, there's actually an increased need for substance use disorder specialists. And there's an increased need for system navigators or case managers. There's an increased need for co-occurring disorder clinicians and case managers, those who are comfortable working with mental health issues and substance use disorders. There will be more and more integration within behavioral health and with primary care physicians in the future. Anticipate the continued expansion of substance use disorder services in the county. We're serving an increased number of clients and also an increase in the types of services available to clients. So that's really great news for all of you that are coming into the field. I would anticipate for at least 2 more years that we will continue to see job opportunities. That's it for today's lecture.